morning. I'm Kate Davidson. It's so wonderful to be here with you all. I'm the director of the Learning and Diffusion Group at the CMS Innovation Center, and I have the pleasure of getting to work with many of you on the Healthcare Payment Learning and Action Network. I also just wanted to say thank you to Alice and Mark and John for this morning's remarks. And I'm so excited to get to hand over the panel today to hear from our leaders at CMS, Liz Fowler, Meena Shishmani, Dora Hughes, and Dan Tsai, who are going to talk about the efforts that they've been doing across the agency in order to support alignment. So with that, I'll hand it over to you, Liz.
Thank you so much. Thanks, Kate, and thanks for organizing a really exciting meeting. It's so nice to see everyone in person. So we've got a lot to talk about this morning. Joining me on the panel are my colleagues, Dr. Meena Shishmani, who leads the Center for Medicare, Dr. Dora Hughes, who leads the Center for Clinical Standards and Quality, and then, as Kate said, Dan Tsai, who leads the Center for Medicaid and CHIP Services. And the purpose of today's conversation is really to give you a better sense of how we're working across the agency to promote value-based care and engage payers across the system. To really achieve health system transformation, we need to be working and also to improve the care experience for the patients we serve. We need to get all payers, Medicare, Medicaid, and commercial payers, on the same page and moving towards the same, in the same direction with the same goals. So each of my colleagues here work closely to promote value-based care, and you're going to hear how they've prioritized collaboration and partnerships outside of CMS and learn from experts and drive delivery system reform forward. I won't go into detail about with their bios because you can find them online. So we'll just jump right in. So each center at CMS approaches the health system from a different perspective and sometimes with different patient populations, benefit structures, and focus areas. But our collective goal remains to improve the care experience for all Americans by breaking down the silos and reducing fragmentation to deliver coordinated, integrated care. A lot of those goals that John Blum, our Principal Deputy Administrator, talked about earlier. With that in mind, my first question is for you, Meena. In the past year, the Center for Medicare has worked to improve patient experience through administrative action under both traditional Medicare and Medicare Advantage. Could you talk to some of this work to improve the patient experience?
Yeah, absolutely. And thank you for having me. It's great to be here with all of you today. So, a lot of the work that we are doing in the Center of Medicare, Center for Medicare, really is towards how do we open the aperture of how we're viewing healthcare so that we're really thinking about caring for people rather than just treating a disease. And I think that is fundamental to value-based care, right? That's ultimately what we want to try to do. So how do we infuse that into the basic chassis of the Medicare program, both on the fee-for-service side and the Medicare Advantage side? So some examples of that, as you probably saw in our recently proposed physician fee schedule rule, about proposing payments for care navigation and for community health services and payments for caregiver training. Again, so that and payments for social determinants of health risk assessments, so that we can really encourage, at its foundation, a broader view of what healthcare means that then provides the opportunity for people to develop their muscle memory and population health and to then move into more advanced models. I think similarly, the work we're doing to be able to take aspects from the CMMI Innovation Center, from models that they have tested and where something has worked, to again scale it in the Medicare program, with a good example being our rolling out of advanced investment payments, where we give money up front to smaller providers in rural and underserved areas that they can use to invest in infrastructure and teams to then become an accountable care organization. That is taking something straight from the Innovation Center. And on the Medicare Advantage side, really looking at how we can also improve that beneficiary experience. For example, by recent regulations on streamlining prior authorization, so that a Medicare Advantage plan has to follow a local coverage determination or national coverage determination from traditional Medicare. Beyond that, if they have prior authorization, it has to be from well-documented, publicly available clinical guidelines. And once you give a prior authorization, that moves with the person if they change plan, and it stays with the person for the duration of treatment. You might have heard also that we're doing a lot of work around marketing to make the navigation. We're in open enrollment right now. Note, we're in Medicare open enrollment right now, so tell everybody to go check their options. But where we can make it easier for people to understand what their options are. So those are just a few examples of how we really are putting the beneficiary at the center of what we're doing so that we can make sure that we're taking care of the people that we serve.
Well, you know it's open enrollment when you turn on your TV, that's for sure. Thank you, Mina.
And we have rejected more than 300 ads that have been misleading. So we are continuing to work on this.
I think the audience really appreciates that effort. Maybe another 300 more. Okay, well, let's move to Dora. When talking about improving patient experience, it's hard to overstate the importance of how we define and measure value and what constitutes high quality care. And at CMS, really your organization, the Center for Clinical Standards and Quality, is a leader in this work. Can you highlight some of the work that CCSQ has done to promote the patient experience in quality measurement and create alignment in quality measurement across the different sectors of the healthcare system?
Yes, and thank you so much for inviting me to join you on the panel today. It's good to look out and see so many friends and former colleagues in the audience. And I also just want to congratulate Kate and her team for putting together just an amazing summit here today. For those of you that are familiar with the Center for Clinical Standards and Quality, or CCSQ, obviously our primary mission, our goal is to promote high quality, safe, equitable care for all of our beneficiaries across all of our programs. And for us at CCSQ, our work is guided by the CMS National Quality Strategy, which we helped to develop and is being implemented across all of our programs and policies here at CMS. And through the National Quality Strategy, there is a prioritized focus on beneficiary engagement. We think that that is absolutely critical. And as many of you may know, as one example of our work through MIPS, we currently have 17 patient-reported outcome measures, or PROMs. Through rulemaking, we have proposed now it would be a total of 21 patient-reported outcome measures. In addition, we have measures, have an annual call for measures for our qualified clinical data registries. This year we were happy that we received 39 measures that were sent forth for our consideration. And so again, through this work, through these, both whether through MIPS or through the annual call, we're excited to see the continued momentum and interest in all of these measures. In addition, though, certainly we do solicit the beneficiary voice, the caregiver voice, through our technical expert panels, our stakeholder engagement. Certainly, we're always cheered to see the number of comments that come from individuals themselves, and so we look at all of this input holistically. But I want to mention two other, as many of you know, our consensus-based entity, the Partnership for Quality Measurement, has a significant focus on bringing in individuals, caregivers, patient advocates into their process. We just had our first in-person meeting a couple of weeks ago, and we're just very, again, encouraged by the very robust participation by individuals, caregivers, representing our beneficiaries, if not beneficiaries themselves. And the final signal I would mention, we are starting to work with our colleagues at ARC, the Agency for Healthcare Research and Quality, to think about how can we modify CAHPS and HCAHPS in part to bring forth more focus on patient experience. And so we think we have made meaningful progress, and certainly you can expect to see more moving forward. So you did ask about a second meeting topic, so I'll stop there with that and talk about alignment. As many of you know, alignment of measures has been another significant area of focus for us here at CCSQ. Earlier this year, we released the Universal Foundation of Measures, which is our effort to harmonize measures for patients, for adults and children in ambulatory care settings. We have included some of these measures already across our efforts through two CMS Innovation Center models, both Making Care Primary as well as the AHEAD model. the state's advancing all-payer health equity approaches and development. I think that's close. I should ask you, Liz, if you know the acronym for ahead. But we included some of these universal foundation measures there. Our colleagues through Marketplace and their quality reporting system will include the measures. Certainly for us in our primary care, MIPS, MVP value, MIPS value pathway have included some of the measures. And so we really think that if we're able to continue to align, promote these common measures, that we will help to both reduce burden, reduce confusion, and really shine a spotlight on areas that require, we think, additional focus. And we intend to move from measures for ambulatory settings to those across facilities, starting probably with hospitals and post-acute care settings. The other, I think another important point for us, though, even as we have all of this work internally at CMS, we are starting to work beyond CMS to engage our colleagues at the Centers for Disease Control, CDC. I mentioned AHRQ, ARC. We're also trying to engage commercial payers through the collaborative. We don't think that we will be effective in the long run unless we're able to bring all the partners together, again, to really help us think through how do we standardize and harmonize measures. And we think that that could be a particularly helpful role for the LAN, certainly through the multi-payer alignment strategy as we move forward if we're all acting in concert. So I'll stop there, but appreciate the question on 2 of our priority areas for CCSQ.
Thank you very much. I think that's probably music to the ears of a lot of folks in the audience to think about this harmonization and alignment. So really exciting, and look forward to hearing more about HCAPS and CAPS and your efforts there. So thank you very much. Turning now to Dan, and sorry you're not here on the stage with us, but nice seeing your face on the screen. Medicaid waivers are a powerful tool to test and advance innovation and advance patient-centered delivery system reform at the state level. Dan, could you talk a little bit about how states are using waiver authorities to advance accountable care, improve patient outcomes, and promote delivery system reform? And I might note, Dan was doing this as Medicaid director in Massachusetts and now has the chance to take some of those innovations nationwide. So look forward to hearing more about that.
Sure. Thanks, Liz. And I'm sorry to not be there in person with you all today. It's always nice to be situated there and to think about delivery system topics across the entire market. And so I think that's part of the gist of this panel. And second, I would just say it's a challenging and exciting time for Medicaid now. And underlying a lot of the exciting delivery system things I'll make a note on in a sec. Core to population health and improving outcomes and anything we want to talk about for delivery system reform or payment reform, you've got to have coverage and access. And when you talk to ACOs or health plans or primary care providers all the time, if you have folks coming on and off of coverage or people losing coverage substantially, that is a challenge. And in this moment, when I think, as many of you know, we are going through across the country, having restarted Medicaid renewals across each state, a huge priority is making sure everybody maintains coverage, and that we're also helping states, working with states to lower the churn that happens historically. And so, some of the really exciting things where we've not only with some states in 1115 waivers done continuous eligibility for kids up to age 6, or continuous eligibility for adults for 2 years, or chronically homeless adults for 2 years. Those are all exciting underpinning pieces, as well as taking a look at how equitably and easily the Medicaid population, our folks can access primary care, mental health services, et cetera. And all those are underpinning any discussion around value-based care and delivery system reform. With that said, there's an incredibly exciting amount of activity happening, not least of which is the way in which we, CMCS, on the Medicaid and CHIP side, are partnering with Liz and her team in the Innovation Center to try to align efforts at the state level for primary care-based, population-based models. There are a number of states that have jumped in some of the CMMI models with a strong Medicaid focus. It is how we've knit together some of our various big 1115 demonstrations, and in recent states like in Massachusetts or some of the other negotiations with some states we have underway, we're trying to interlock substantial new investment in the safety net in providers with pairing that with continued support and accountability for enhancing primary care, for ACO-like models, for really taking on accountability for total cost of care, and importantly, outcomes. And so those are exciting pieces. The last thing I would say that has been a prevalent theme throughout our 1115s and waivers in the Medicaid space is pairing delivery system reform with a real emphasis on primary care, and then also the health-related social needs pieces. For our population, it's really hard to think about improving outcomes, certainly without coverage, to my first point, or the ability to access primary care, but also without some of the housing, nutritional instability, and other needs having some way to be met appropriately with guardrails within the Medicaid program. We forged really exciting policy on that. And so those things in our minds all tied together, and we want that to be part of a cohesive statewide effort that certainly has a Medicaid flavor and a bent to it, but situates within some of the overall delivery system reforms that we're really closely partnered with CMMI around.
Thanks, Dan. I really appreciate that. We have been partnering very closely at the Innovation Center with Dan and his colleagues, as well as with Mina and her team. And I think it's been really important work. And so I'm going to take the moderator prerogative and just highlight how our work has been prioritizing state partnerships more meaningfully than ever. And I'll just mention a couple efforts, the Making Care Primary, which Dan mentioned, and then the AHEAD model. Dora, the reason you come up with a catchy acronym is so you don't have to remember all the words that spelled out AHEAD. So the AHEAD model, we'll just leave it at that, represents a real step forward in multi-payer alignment and really deepens that partnership between Medicare and Medicaid. So starting with the Making Care Primary model, it builds on a decade of experience of the Innovation Center's models and experience testing primary care. It's really geared to provide an on-ramp for safety net organizations to join value-based care and small and independent primary care practices. And thinking about the model and how it's different from previous models, instead of sort of a mile wide and an inch deep, instead of going into 26 states, we really chose states where we signed agreements or MOU type arrangements with state Medicaid agencies and health authorities. And so we are committing and with those Medicaid agencies to alignment, multi-payer alignment on quality measurement, data sharing and learning supports, and really moving away from fee-for-service payments. So the goals with those payers will be the same when we try to reach out and I think incorporate what we hope will be commercial payers in the model, and also seek a commitment to directionally align in those areas. The other model, the AHEAD model, is a multi-state model. We just announced that most recently, and it aims to curb rising healthcare cost growth and improve population health and health outcomes and address disparities, which are similar themes across all of our models. But in this case, a really significant restructuring of health spending across all payers in a state or region. The idea is to make investments in those areas that we know will improve health and health equity in the long run, like primary care, and offset those additional investments through reductions in spending and utilization in other areas to contain total cost of care growth. So it's really an opportunity to expand accountable care through statewide accountability. And again, we're starting with Medicaid, working very closely with states. States are the applicants for that model, and thinking about setting statewide targets and provider alternative payment models. And while we are designing that model to work closely with states, and we have some, of course, core elements, we want to be able to meet states where they are. So hopefully we're giving states enough flexibility to come in with some of their priorities and support their ongoing transformation efforts. But again, it's in both of these models, it's really the partnership with state Medicaid agencies and health agencies that's really a core component. So I think that's really exciting, and looking forward to continuing to work with Dan on that. While we all like to highlight successes, if health care delivery system reform was easy, it would be done by now. So this work certainly has some of its challenges. And, I know this is true as well. And our principal deputy highlighted it. What do we mean by value-based care? I think at the Innovation Center, we certainly talk about what value-based care is, but I think everyone has in their mind something different. And so one challenge we face is really explaining what we mean by value-based care and why this approach is better for patients. But maybe could each of you share what you believe has been maybe a significant challenge facing value-based care and accountable care within your own programs? Maybe start with Mina, then go to Dan, and then to Dora.
Only one?
Well, you can ad lib because I know you have challenges.
I think, I will give two, and I will say I agree that one of the biggest challenges is having people understand what it is. And I think that's important both from the patient side, right? So they know what they are able to get to be able to engage, and from the provider side so that they also know what are these models, what are these new ways of caring for people. I think that ties into, one of the big challenges that I have seen as I have traveled around the country, met with providers, met with patients, is just the feeling like it's a bar that's really high. Like, I don't know how I would be able to get there. How I would be able to get there, both from the standpoint of the resources that it takes to be able to invest in the kind of infrastructure, teams that you need for that kind of care, as well as I don't know how I would be able to get there from the perspective of, well, I've never had a partnership with a community-based organization before. How do I do that? I've never worked with, had a social worker in my clinic. How would that happen? And I think that's some of why, we've been making some of the policies that we have in alignment with, Liz's team to really try to get those upfront resources where they're needed, to try to provide through our ACO learning community best practices that can be shared, and to be able to bring some of the best practices that work into the fee schedule overall so that you address some of the cash flow issues that can otherwise happen. Well, okay, I could hire a community health worker now with the hope that 18 months to 2 years from now, we have shared savings that come back. And so that's some of a way to address these things. And the second comes back to what Dora was talking about with alignment. Particularly just within the Medicare program, there are so many different programs, all these different metrics. When I was leading care transformation at a health system, we had this huge spreadsheet with like 8-point font of all of the quality metrics for all the different programs. And when I was going to my clinic the night before, I wasn't looking at which payer and which program each of my patients was in. And if I'm not going to do that, it's not really realistic. And so how do we, piggybacking off of what Dora said, how do we get better alignment? Because then the conversation is not, should we be targeting hemoglobin A1C greater than 8 or hemoglobin A1C greater than 9 for diabetes? Instead, the conversation is, what do we do to take better care of our diabetic population so that you can really drive change on the ground? So I think those are two challenges with my +1 for the needing to explain things in simple language.
Well, that 8-point font chart is really powerful and really speaks to the
Honest
need
to
and the
God.
importance of that alignment work that Dora is leading. Dan, what about you?
I'd say, well, I'm going to do the same thing Mina did, say two things. I think that, but they are a repetition of what I just said. So the first piece I really do believe is coverage. And it is really difficult for safety net providers and also our enrollees to be engaged in population health when we have the risk of people not maintaining their Medicaid coverage as we go through Medicaid eligibility renewals, or the data we've been looking at, which is the incredible amount of churn, to use that word, of people who are, who lose coverage at their 12-month renewal mark and come back over the course of X number of months. None of that promotes any level of continuity or even the ability for providers and health plans to make long-term systematic investments, or if you're not sure if you can get your kids medication paid for, that starts with certain dynamics. So that's why we have put so much emphasis in that realm. I think the second challenge is in the Medicaid space, there's no secret that the reimbursement levels are challenging, and in many places across the country, for our Medicaid population, we don't feel like there is the same equitable level of access or even the timeliness of how you can see a primary care doc as for the commercial population, MENA for the Medicare population, et cetera. And so there's certainly a level of reimbursement issue and other things tied to that without addressing becomes very hard to talk about how providers can move into more global risk or other models. I think at the same time, it would be fair to say, with more funding comes more expectations, but it's hard to ignore the underlying funding and reimbursement challenges that we do see in parts of the country, and to be able to expect providers to be able to move fully into alternative delivery and payment models. So those are underlying pieces. They are solvable with the right investment and focus and creatively linking more investments, substantially more investments or new payment models and investments in primary care, mental health, et cetera, with some of the other pieces. But they really, in our view, need to go hand in hand. And that's some of what we've started to do in the 1115 demos we talked about earlier and have worked very closely with Liz's team on.
Great, thank you, Dan, and it's okay. And Dora, if you want to add, one more, a +1 to your challenges, that's okay too.
I'm going for 2 as well. No. I did just want to say, I was laughing a bit back to Mina's original point in that chart, because I would point out that Alice Chen sent me her 8-point font chart with all the measures laid out. Just as I assumed this role, she just wanted to be sure I was clear on the challenges that certainly we're facing, but all of you are facing in your day-to-day work as well. So I appreciate that. So the incentives, I have to say +1 on that for sure. Both the upfront infrastructure costs, but the ongoing cost of participation is what we hear. But we're also hearing that we are not providing granular enough cost and quality information, the data that can enable providers to improve. We're also even hearing that even the information, the data that we are providing, the timing is off. And so it's not allowing providers adequate time to improve before in time for the next cycle. And so we are certainly hoping to hear again from all of you. It's very helpful for us, particularly when you get down to the specifics, so we can think about what's technically feasible on our end, what changes that we can make to address some of these challenges.
Great, thank you. Really appreciate that. And indeed challenges, but also, in these roles, we have a lot of opportunity, which is really exciting, and a lot of opportunity to advance value-based care across the industry. And so maybe focus the remaining time on possibilities and opportunities. And I'll start with you, Mina. Can you talk a little bit about the vision for the Medicare Shared Savings Program and how it can serve as a platform to test new models and approaches in care delivery?
Absolutely. So, Liz and her team and myself, my team, we put out a piece in the New England Journal on our ACO vision, and then a follow-up piece in Health Affairs, talking about one of the themes that we've been discussing in this panel about alignment and how the Medicare Shared Savings Program, it is the largest accountable care organization program in the country with more than 10 million beneficiaries, more than 500 and some thousand healthcare providers. So how can we leverage that to reach our 2030 goal of 100% of traditional Medicare beneficiaries in an accountable care relationship, and to drive what that accountable care relationship should be? And it's really using MSSP as the chassis both for growth and for testing new opportunities. And I think that you have seen us do that in a few ways. Number one, really through feedback from many of you, being able to make meaningful changes, pretty significant changes to the Medicare Shared Savings Program to encourage more providers to participate and to encourage them to stay in the program. From how we've proposed changes in attribution of beneficiaries to include physician assistants, nurse practitioners, because we know that the way of practicing medicine has changed, to changes that we have finalized with the benchmark. And also where we're taking ideas that have worked from the Innovation Center to bring into MSSP, like the example I mentioned with the advanced investment payments, piggybacking off of the ACO investment model that CMMI had done, that providing upfront shared savings to small providers in rural and underserved areas is really a good investment, because they more than deliver on the shared savings and really to pay back and really improve the quality for some of the communities who need that most. And we're continuing to look to where the Innovation Center can test new ideas for payment within MSSP, because then you make it easier for people to participate, and it's easier to then see what is the benefit, what is the effect of this change, and if it works, then it's easier to potentially scale it within the Medicare program.
Yeah, I've really appreciated the partnership with Mina and her team, and I know speaking on behalf of our team, and in addition to the AIP program, we're now looking and seeing what aspects of ACO REACH might be appropriate to scale into SSP, as well as continuing to think about what that opportunity is for using SSP as that, as we call it, chassis for innovation in the future. And it's not to say we won't do a standalone model in the future, but we really want to harness what's already happening and all the great things you're doing, and think about doing a standalone model. The downside is that you're really forcing organizations to move between programs, and sometimes the rules don't align. So we really want to take full advantage of the shared savings program. Maybe turning now to Dora. And can you talk a little bit about how we're continuing to build on the national quality strategy to advance more patient-centered care? I know, what is CCSQ thinking about how we work to change how we track and evaluate quality of care that a patient receives?
And Liz, I really liked your framing, that instead of thinking only in terms of challenges, but also thinking what are the opportunities. And for us, we are, through the prism, through the framework of the national quality strategies, really thinking about what can we do moving forward to really focus more on the patient experience, to embed more patient-centered care actions. And really, I would describe it in 3 ways. I mean, first, we're really thinking about how do we build upon our current approach to really look more holistically from birth to the end of life, to look across all of the payer types, to look across all settings of care, from home and community-based to hospital to post-acute care. So we're really trying to take a step back and really think about what are the gaps in our current focus, where can we collect, where can we do better in terms of advancing patient experience care, including quality measurement. The second area is for patients. We will admit we still don't know enough, and how do we better include patients in a collaborative fashion in their decision making. And that's an area that we are exploring, and as part of that, when we think about how do we include patients, we also want to make sure we include all patients. And we haven't really touched on health equity in this panel, but I would be remiss if I didn't at least mention Mina and our efforts from both of our centers to finalize the Rewarding Excellence in Care for Underserved Populations, the RECOUP model, that's providing extra bonus points for providers and hospitals, SNFs, that are doing an excellent job in caring for the dual eligible patients and getting them appropriately incentivized to continue that work, reward those doing that work. For CCSQ, we also finalized measures for social drivers of health, not only screening, but also a measure on how many of your patients tested positive for needs in the areas of housing or transportation or food. We think it's really important to drive holistic, full patient-centered care to know not just their clinical needs, but also their social needs as well, and again, across all underserved populations. And the third challenge and opportunity for us is really getting back to the data. We are collecting more data on patient experience than we ever have through all of our facilities. We just finalized a focus on inpatient psych facility. I think that was maybe the last facility that had not, we were not collecting patient experience data from, so that would now include all the variety of inpatient and outpatient facilities. But we also realized that this patient experience data is really important for us, But we also, how do we put more data in the hands of patients that ultimately can improve their experience? What are the investments we need to make in patient portals or other resources? That's an area that we could use assistance from all of you. We're just really also thinking about what are the measures and how are they relevant to patient populations. An example is our efforts to report on the number of procedures that a provider has done and putting that on our compare tool on the website, so then patients will know this is maybe is the provider we should be going to see. And of course, that transparency incentivizes performance on the quality side as well. So we think across those three areas that would represent great opportunities for us to advance patient experience, really thinking about patient-centered care. And again, an excellent opportunity for us to collaborate within CMS, but all of you.
Great, thank you. And maybe, Dan, continuing that theme of sort of the optimism and possibility, what are some of the more promising ways you're seeing states leverage partnerships to advance delivery system reform?
Yeah, I like that lens, Dora, or everyone, on the opportunity or the whatever, the two sides of it. So I think three. I'd say one, we are seeing a lot of states really think about investing upstream in primary care and mental health, paired with delivery system reform pieces, which completely aligns, Liz, with everything we've been talking about for things like making care primary and others. And there's some really exciting pieces. Primary care subcap, not so much for the purpose of risk as much as really helping primary care get off of a fee-for-service treadmill. People taking a look at fee schedules to bring primary care fee schedules from Medicaid at least up to Medicare, things of that sort. The flip side, so that is exciting to recognize that there's a need for investment and support and really helping to get off of the fee-for-service payment model, paired with, how to have expectations around that. I think the flip side of the opportunity or the challenge is it's really hard to figure out. I mean, resources at most states are still quite limited from a budget standpoint. And so to really get the scale and impact of investment and full-on statewide multi-payer delivery system reform, I think is still challenging. For a second piece, there is a lot of push and excitement at the state level for alignment. Just the number of states that have been interested and signed up, raised their hand for making care primary, the number of states with interest in ahead, the number of states that come to us and say, how can we align across more of the Medicaid as well? That is really exciting, and I think hopefully news from a provider standpoint as well. I think the flip side of the challenge is when we get into some of those discussions, there are things that we want to see equitably and very similarly across all payers. And then there are things that are unique about populations. And in Medicaid, we cover more than half of kids in the country. And that has less of an overlap, for example, Mina, with your population. And so you get into different types of practices and the nuances of that. And sometimes things are easy to intersect, sometimes not. And so that continues to be an area of opportunity for similar thematic delivery system elements, even as we think about different populations and different segments of even, primary care. I think the third is for social determinants and health-related social needs. As I noted, it's really exciting. We have forged new policy from a federal standpoint about what we think an appropriate role is for Medicaid in the care elements and also in the financing with guardrails of housing and nutritional support. And we've seen states really start to integrate community-based organizations and others with the expertise on the ground there. At the same time, you get a constant push and attention, the how to have the health-related social need part just sit on the side. It really needs to be integrated in from a care and delivery standpoint. But you're bringing different parts of, the traditional healthcare system and some of the experts and CBOs and others that operate in the housing and nutritional space don't always have a shared language or history or success of working together in this way, or even how to exchange data. And you sometimes get a lot of tension of who controls what dollars, or are you building or buying? Are you duplicating capacity? What are the right accountability expectations? So I think that continues to be a really important piece for the health-related social need to really come into how we think across Medicaid about the delivery system, and not just to have it sit on the side as a cool thing that wraps around. I think that is both an area of exciting progress made and a lot of opportunity that exists.
Well, that's great, and that's a lot of opportunity. And I hope the audience is getting a sense for the partnership and collaboration that you see across the agency, which I think is what makes my job fun and hopefully makes it fun for my colleagues as well. Feel really lucky to be working with such great leaders, as well as Kate and her team, which put on this great event. You know, it's funny because I looked at the list of questions and I thought, there's no way we're going to get through all these questions, but we did, and hopefully we've given you a sense of what it is that we're up to, and also just want to say that, you know, the LAN is such an important element for us to hear from all of you. This is a multi-stakeholder, including the patient and consumer voice, which is absolutely critical, as you heard from my colleagues. So this is an important forum for us, and we wanted to give you a sense of how we're working together and how we share the same goals of promoting value-based care. So hopefully you got a sense of that, and just want to thank my colleagues and turn it over to the next forum. So thank you all. Really appreciate the discussion.
Thank you.